So at this time, we will go on to our first speaker, Dr. D'Souza, Dean of St. John's, joining us from Bangalore. Professor D'Souza, who is from batch of 1975, completed his medical training at John's, after which he did post-graduation at the prestigious PGI Chandigarh. He went on to have training in sleep medicine at Beth Israel Hospital at Harvard Medical School. He returned to St. John's and has served John's in various capacities. Currently, he is the professor and head of pulmonary medicine, as well as the Dean of St. John's. Professor D'Souza, please take over.
Thank you, Sudhir, and hello to everyone who has joined this meeting, and thank you all for being part of this on the weekend. When Sunil asked me to speak as part of this webinar, we really didn't have many COVID patients in Bangalore, and but we were affected by COVID in all its variety. And so I thought it would be useful to see what St. John's did for COVID. I see a small number of people who are not Johnites, and that's why I put up this slide. St. John's is a medical school started in 1963, run by the Catholic Church of India. And its main mission is to provide quality health care which is accessible and affordable to the poorest, and also to train healthcare personnel who will serve in the medically underreached and underserved society. Now, COVID, as you all know, you know how it has come into the world and how it has become a pandemic. It came into India from China, into Kerala through medical students who had gone there to study. But it also came through Europe, it came through the Middle East, and more recently, Indonesians who had gone for religious function to Delhi and then spread out across the country. But at the moment, probably the main rise in cases is related to the migrants who are now going back to their households. This map shows you the distribution of cases, and the red spots are the ones where we have a large number of cases. Fortunately, in Bangalore, we still do not have such a large number of COVID patients, and hopefully it will remain that way. But as things are happening, it seems to be increasing. Now, when the COVID pandemic started, our objectives were to protect our healthcare workers, to continue all services, COVID and non-COVID, especially for the poor and middle class, to continue training and research. I'll discuss under the following headings: human resources, training, protocols, infrastructure, PP, communication, teaching, research, and dealing with the community. The first thing that we did was to form a COVID task force, and it consisted of executives. It consisted of non-teaching HODs, including the clinical staff. It consisted of nursing staff because we felt that they were all required. And this group meets on a daily basis to tackle the situations that arise on a day-to-day basis. Our major strength has been our human resources. As you can see here, we have not been affected badly in terms of the number of faculty, number of residents, nurses, technicians, housekeeping staff that we have. But what we needed to do is to deploy these people in an appropriate manner. We needed to define what the role allocations were. For example, we needed to decide who would take care of the screening clinic, who would take care of the isolation wards, who would take care of the regular work, etc. We needed to make rosters for two reasons. One, we wanted to have sufficient staff who would be available at any time, because we weren't sure whether some of them would be hit by the virus itself. And secondly, because large number of people coming in would have affected the social distancing, etc., that would be required. And lastly, we had to take care of any surge that might happen because of the COVID. Now, these staff needed to be trained, and they had to be trained in depending upon what areas they would be involved. We needed to do something for all the staff to get an idea of what the infection was about, what they need to do to protect themselves and at the workplace. But then we required some specific things, and that was also done. We also had to define protocols, and these protocols were for screening, for investigation, for treatment, and for the use of PP. As you can see in the screen, the discharge criteria were made into placards. There was also a screening algorithm which was defined, and these kept changing very frequently, so they had to be modified on a day-to-day basis. And hence, we developed a team which would take care of this, which would look at what the government was putting out in terms of who should be screened, who should be discharged. We also looked at the literature that was coming out, which was changing rapidly, and helped improve our protocols as we went along. So now coming to the infrastructure. Now, we required to have a screening clinic. And the first thing that we did, for those who know John's, the entrance of the hospital, we have a PRO's office, which we converted, but that was not a good idea. So we changed it to the entrance of the inpatient. We blocked off that area. And then, as you can see in the picture there, we formed a screening clinic that then went on to also form the emergency, to develop the emergency of COVID, to deal with the emergency COVID patients. You can see on your right-hand side, we created a kiosk to be able to do swabbing. Now, RT-PCR initially was centralized. It was done only in the National Institute of Virology lab, which is present in Bangalore. They suddenly stopped testing our patients, and we had to go to the private sector. Fortunately, we had good relationship with one of the lab, Anand Diagnostics, but we decided to apply to be accredited to be able to test in John itself. And that was done very well by our lab. This was a very difficult task because it had to be accredited by NABL, and this accreditation had to be done from distance by online monitoring, and that audit process went on for 5 hours, really going to late in the night. And we have tested so far 406 patients, but we have seen only 4 positive. That again tells you that at the moment, Bangalore is still a low prevalence area. We had to create isolation wards. Initially, we made 10, but the government of Karnataka wanted us to have at least 100. We were lucky because the new block that is being built was there. We furnished it quickly. We added oxygen, suction, etc. And soon we were able to set it up. We had one for suspects and one for positive patients. We have so far isolated 194 patients. We also created one of the wings of the private ward for healthcare providers. And so far we've had 60 healthcare providers who needed admission for suspected COVID, but fortunately, so far we haven't had a single positive healthcare worker. Next slide, please. Yeah. The other thing that we had to modify was our ICU. We had only 2 negative pressure ventilated rooms, but rapidly the number of severe respiratory infections coming increased because most of the city people stopped taking these patients. We increased it to 7 and then finally to 15 beds. And we did that by our engineers modified the air handling units in such a way so that we had certain areas which were dedicated to look after patients with suspected coronavirus. We have so far seen about 172 suspects. 80% of them have been ventilated, but there were only 3 positives among the ventilated patients. One died, but he died not of COVID, but of infective endocarditis, and the 2 others went home. Next slide, please. Now, PPE and pharmacy, right from the time the COVID started, we found that PPE disappeared from the market. It was available at very huge costs. And the other thing that happened was large number of people started hoarding hydroxychloroquine and the antiretrovirals and any drug which might be used in the management of COVID. Yeah, as far as PPE is concerned, we had to decide who gets what, and we had to monitor the stocks. We had to source the PPE because all of was not of the same quality. And finally, we even decided to fabricate our own. And some of the institutions, including NIMANS and the Army, used our design because of the huge shortage initially of PPE. Now it is much better. Next slide. We needed to also have means of communication on a daily basis. So we had daily meetings to discuss the issues, and then we had weekly meetings with the HODs to keep them well informed. We disseminated whatever was required on a daily basis using WhatsApp, email, and posters. In the figure that is there, the map that you've seen, those are the hotspots that are in Bangalore, and that comes on a daily basis. And that had to be disseminated to all the faculty and residents, because those are the patients coming from these areas needed to be suspected to have COVID, and that was very essential. Next slide. Now, while we are doing all this, we realized that teaching was not happening. So initially, we asked our faculty to put up their PowerPoint on our student management system, but we thought that was not working. So then finally, we used Teams from Microsoft. We trained our faculty. And the good thing is that both the undergraduates and the postgraduates have had a very positive response of the online training that we have been doing. And this has also been incorporated by the Rajiv Gandhi University. Next. And finally, research. This was an opportunity to do research. Because of the lockdown, we had to ask our IRB to function also in a similar manner like what we're doing today. Some of the studies that have been initiated, one is hydroxychloroquine for prophylaxis, 2 studies on immune changes in COVID-19 infection, 1 on the role of BCG, plasma therapy as part of the ICMR trial, and there are many others also being done, and hopefully they will give us an idea of what about COVID in this part of the world. Next. And finally, we also dealt with the community. Next slide. As you can see here on the left-hand side, our community medicine department involved with surveillance and contact tracing, helping the government of Karnataka. And on the right-hand side, we also had conducted some camps particularly for the migrants, because they were all stranded. So we conducted medical camps. We also distributed groceries for them, because that was a huge human tragedy that happened as part of this COVID, and we thought we had to do something in that direction also. Finally, we also did some educating programs for factories, etc., to be able to help them to understand and cope with COVID. Next slide. Next slide. But all this happened with the financial impact. As you can see here, our outpatients from 2,400 per day dropped to 300, and now has picked up slowly to about 1,000. And our inpatients have dropped from roughly about 1,000 a day to only about 200, and is slowly picking up to about 300. This had a huge impact. So we had to think of mechanisms means by which we had to improve our finances. Next slide. One of the things that we thought of was teleconsultations. Initially, we did it to just keep our patients in touch. We sent SMSs to about 68,000 people who were on our rolls, and we did free audio teleconsult initially for them. But now we have activated a paid teleconsult. We also offered home lab tests. Samples would be collected from home. We already had a process in place, and 7 kilometers around the college, we are able to take orders for blood tests and process them and give them the reports. We are also finally thinking of filling up prescriptions, and we are trying to use one of the these new organizations like Dunzo and Swiggy to be able to give the give the drugs to the patients at their doorstep. Next slide. Yeah, this is Dr. Avinash, who set up our teleconsultation, and this is how the portal looks like. Next. Yeah, so finally, managing a pandemic in an academic institution needs a lot of thinking in terms of infrastructure, in terms of forming protocols, in terms of staff training, supply chain, maintain teaching, research, and most importantly, also finance. I thank all my vice deans, my associate medical superintendents, heads of departments, faculty, residents, nurses, and paramedics. And thank you all for a patient listening.
Thank you, Dr. George, for sharing how St. John's has responded to this pandemic so far. Careful preparations always help, and we've seen that all over the globe, especially I would call out to the state of Kerala for the amount of preparations that they had done. But I have a question for you, Dr. D'Souza, from one of our attendees, and it's all over the world, there has been a proliferation of counterfeit products as far as personal protective equipment goes, and 95 masks especially. Are you seeing that to be an issue in St. John's? And if so, how can you face that?
So you're right. I do not know whether you could call them counterfeits, but adequate PPE, because everyone is now manufacturing PPE, and that's how the prices came down. But so what are we doing is, any vendor, we are asking them for samples, checking them out, getting our faculty to check that out, and only if they're satisfied, then are we purchasing it. Second thing is, there are some vendors who are known to us from before, so who are reliable. So those are the vendors that we have been dealing with, and hence we've not had such a major problem as far as acquiring quality PPE. And like I told you, we also designed our own PPE. We got the material that was required, the 80 GSM that is recommended, and we designed it ourselves because our critical care department actually felt that designing it worked for them much better. But unfortunately, we could not keep pace with the demand that we required, so we had to purchase some from outside.
Thank you, Dr. D'Souza.